Okay, good day, sir, and good day, everyone. We are the group 6, and we're going to present hemophilia A and hemophilia B. Sorry for the noise. Okay. So hemophilia A is an inherited, specifically X-linked recessive bleeding disorder resulting from a congenital deficiency in factor 8 or factor 9. So X-linked recessive siya, meaning yung mostly affected ay males kasi as we all know, yung chromosomes ng male ay X and Y, while yung mga females naman yung mga affected females, normally, mga carriers lang sila kasi yung chromosomes nila ay dalawang X. So, yung isang X chromosome is unaffected. So, parang ganun lang yung basic explanation ng X-linked recessive bleeding disorder. Hemophilia A is characterized by the deficiency of factor 8, yung most common na um, type ng hemophilia is hemophilia A, while hemophilia B is characterized by the deficiency of factor 9. And these two are both clinically indistinguishable. So meaning, hindi mo siya agad-agad mas-specify kung hemophilia A or B pa unless mag-dig further ka dun sa lab test results ng patient. So, for the physiology, as we all know, the coagulation mechanism is intricately balanced and designed to stop bleeding at the vascular injury site by complex interactions between the vascular endothelium, platelets, procoagulant proteins, anticoagulant proteins, and fibrinolytic proteins. And hemostasis, yung function niya talaga is to normally to stop the bleeding at the site of vascular injury by impermeable platelet and fibrin clot formation. So, dun sa hemostasis na yon, meron tayong three key mechanisms that facilitate hemostasis. We have the vascular constriction, the primary platelet plug, and the clot propagation through fibrin formation. Sorry. So first, yung vascular constriction, this is the first mechanism to occur after a vascular injury na kung saan yung vascular smooth muscle nag-automatic na nagko-constrict siya na kung saan pag nag-constrict siya, magde-decrease yung blood flow dun sa blood vessel. So thus it helps prevent or limit blood loss. And yung next mechanism is yung primary platelet plug, also called primary hemostasis or platelet migration and aggregation. Dito naman sa step na to, yung nangyayari yung accumulation ng platelets that can seal up a small vascular injury. And lastly is yung clot propagation through fibrin formation, also called the secondary hemostasis or yung coagulation cascade. So, dito tayo mas magdodwell kasi dito involved si factor 8 and factor 9 na deficient sa hemophilia A and hemophilia B. Dito sa clot propagation or coagulation cascade na lang para mas ma-familiarize tayo, meron dalawang pathway, merong dalawang common, dalawang tawag dito, major pathways dito sa coagulation cascade. We have the intrinsic pathway and the extrinsic pathway. Sa intrinsic pathway, ang mga exclusive factors involved dito ay yung factors 12, 11, 9, and 8. And itong intrinsic pathway na to, it begins with the activation of factor 12, of course. And yung activity ni intrinsic pathway, ma-assess natin kung tama ba yung activity niya or nagpo-function ba siya ng maayos via this lab test na tinatawag na activated partial thromboplastin time or the APTT. Later, i-discuss yung mga normal values ng intrinsic path and itong activated partial thromboplastin time. And sa extrinsic pathway naman, ang exclusive factor na involved dito, exclusive meaning doon lang siya sa extrinsic pathway lang siya involved, parang ganun. Yung 7, factor 7 yung sa extrinsic pathway. So again, yung exclusive factors sa intrinsic pathway, factors 12, 11, 9, and 8. Yung exclusive factors na involved sa extrinsic pathway ay yung factor 7. This extrinsic pathway, it begins with the release of thromboplastin from the damaged tissue. So, kung sa intrinsic pathway, ma-assess natin siya via the activated partial thromboplastin time. Ito namang extrinsic pathway, ma-assess natin kung tama ba yung activities or yung function niya na maayos ba via this laboratory test na tinatawag na prothrombin time. And abnormalities in this system, these pathways can lead to either bleeding disorders or thrombosis. So, ito po yung summary, yung sinabi ko kanina na major mechanisms ng hemostasis. So, as you can see, um, ito yung with the presence of vascular injury, automatic ang initial mechanism talaga ng blood vessels natin is vasoconstriction para malimit yung blood loss. And ayan, sunod-sunod na yan hanggang sa mag-form ng clot. And then, um, yan. Next tayo, after ng vasoconstriction rather, yung next step, as mentioned earlier, is yung platelet plug formation. Ito yung tinatawag na primary hemostasis, also known as the platelet migration and aggregation. So dito, meron tayong series of steps that occur simultaneously. Ano yung mga steps na yon? As you can see dito, yung number 1, 2, and 3. Ayan, yung steps na yon, we have the first one, platelet adhesion. Second one is the platelet release reaction. And the third one is the platelet aggregation. So, yung first step, platelet adhesion, the platelets stick to the collagen exposed by the damaged blood vessel. This action is mediated through the von Willebrand factor. Von Willebrand factor is a protein produced and secreted by blood vessel endothelial cells that forms a bridge between collagen and platelets by binding to platelet surface receptors and collagen. So kapag nag-adhere si platelets with collagen, na-activate si platelets. So paano natin malalaman na activated na si platelets? Nag-change yung shape nila and nagre-release sila ng chemicals. So, next step is the platelet release reaction. So, upon activation of platelets, nagre-release sila ng chemicals na adenosine diphosphate and thromboxane. And yung role nitong dalawang ito is mababind sila sa respective receptors dun sa platelets and magre-recruit ng maraming platelets para mag-induce ng aggregation. And ayan, paulit-ulit lang yan, magre-release ng ADP and thromboxane, magre-recruit ng maraming platelets para mag-aggregate, mag-form ng aggregation. And then, yung activated platelets na yon, ito 'di ba siya, parang nag-change yung shape nila once activated, perform sila ng fibrinogen receptor. So, ayan. And then, next step, yung last step sa platelet plug formation is the platelet aggregation. Yung fibrinogen na na-form ng mga activated platelets, yan, magpo-form na sila ng bridges between the fibrinogen receptors of numerous platelets. Tapos yun, nagre-result na siya into platelet plug. Pero, yun, take note na hindi pa siya stable. Kasi nasa second major mechanism pa lang tayo, wala pa tayo sa coagulation cascade kasi dun pa lang siya magpo-form ng stable meshwork na kung saan stable na yung clot. So, platelet plug pa lang yung nagagawa dito. Okay. So, next one is the coagulation cascade, also known as the secondary hemostasis. Itong nakikita nyo sa screen, ito yung summary, yung pinaka shortcut, kumbaga, ng coagulation cascade. So, blood coagulation or formation of clot, ito, is the third major step in hemostasis. This complex process involves a series of reactions that results in the formation of a protein fiber meshwork that stabilizes the platelet plug. So dito meron din tayong three sub-steps na essential steps that lead to blood clot formation. Excuse me. So first, we have the activation of factor 10. Second is the conversion of prothrombin into thrombin. And third is the conversion of fibrinogen into fibrin. So, yan yung parang shortcut lang. So, ito yung mas, ano ba yung term? Mas broad na, kumbaga, pinasimple na siya. Pero, kung sa coagulation cascade, ito yung yun na nga, yung simplified na diagram. So, we have here yung dalawa nating major pathways and yung common pathway. We have the extrinsic, intrinsic, and the common pathway. So, itong extrinsic, differentiate natin yung dalawa na bukod dun sa mga factors na exclusive factors na involved, si extrinsic pathway is siya yung fast process, while si intrinsic pathway is siya naman yung slow process kasi nga maraming factors na involved, paano ba? Maraming ina-activate ng mga factors bago siya mag-meet with the extrinsic pathway dun sa common pathway. So the extrinsic pathway, it begins when a blood vessel is ruptured and the surrounding tissues are damaged. The traumatized tissue releases a complex of substances referred to as the tissue thromboplastin. And this tissue thromboplastin further magpo-form siya ng complex with factor 7 and calcium ions to activate factor 10 directly. Ganun lang siya kabilis. Perform lang siya, magre-release lang siya ng thromboplastin, perform ng complex with factor 7, and then activate agad si factor 10 directly. Ano lang. Next, sa intrinsic pathway, um, it causes the blood to clot within the vessel itself and is activated when the blood is traumatized or when it contacts the exposed collagen of a damaged vessel wall. So, ayan. Kapag nagkaroon ng contact yung traumatized vessel and yung collagen, na-activate si intrinsic pathway. So, yung first na na-activate is yung factor 12 or the Hageman factor. And simultaneously, platelets are activated. So, yun nga, simultaneously lahat sila nangyayari and such that they begin adhering to the collagen in the vessel wall to form the platelet plug. And in addition to the adenosine triphosphate and thromboxane, these aggregated platelets also release platelet factor 3. And yun, yung activated factor 12 leads to the activation of factor 11 and yung factor 11 leads to the activation of factor 9 with the help of calcium ions and factor 4. And yung factor 9 with the help of calcium ions, factor 8, and platelet factor 3, it leads to the activation of factor 10. So, ganun yan. Kaya siya tinawag din na slow process na pathway sa coagulation cascade. So, dito na tayo sa common pathway. From the point of factor X activation, yung activation ng factor X, dito na nag-meet si extrinsic and intrinsic pathway. So, they follow the same common pathway to fibrin formation. So, the extrinsic mechanism coagulates the blood that has escaped into the tissue prior to the sealing of the vessel, whereas the intrinsic mechanism coagulates the blood within the damaged vessel. And yung activation ng factor 10 leads to the conversion of prothrombin into thrombin. And yung thrombin naman, siya yung nag-help na ma-convert si fibrinogen into fibrin threads. So, yung fibrin, siya na yung nagpo-form ng stabilized meshwork that traps blood cells and forms the blood clot. So, yan lang. For the coagulation factor, as we all know, coagulation cascade or secondary hemostasis is responsible for facilitating the propagation and stabilization of the initial platelet plug formed in the primary hemostasis through the formation of fibrin on the activated platelet surface. And yon, yung mga coagulation factors na yan, they are divided into three groups based dun sa biochemical properties. So ito yung three groups na yon. We have the vitamin K dependent factors, which are factors 2, 7, 9, and 10. The contact activation factors, which are the factors 11 and 12, precallicrine, and high molecular weight kininogen. And third is the thrombin-sensitive factors, which are factors 5, 8, 13, and fibrinogen. So ito lang yung mga other names ng mga clotting factors. I guess, alam na natin to kasi ito, nakuha ko lang din to sa slide natin sa Pharmacology 1. So, please read na lang to. Okay, so inad ko lang yung fibrinolysis kasi syempre hindi naman pwedeng hanggang parang mag-end na siya dun sa clot lang kasi alam naman natin na kapag nasobrahan naman yung pag-clot, pwedeng mag-cause ng further complications naman sa ating blood. So, we have the fibrinolysis. It is the process of clot breakdown and once na na-restore na yung vessel wall, yung damaged vessel wall, and yun nga, yung structural integrity is na-restore, dun na mag-start si fibrinolysis. Mag-start na yung body na parang mag-command sa ating um, vessels or blood or platelets na okay, stop na, tama na yung clot, okay na yung naayos na, na-restore na yung vessel wall kasi pwede pa siyang cause ng further complications. Like for example, stroke, ganun. Okay, meron lang tayong dalawang steps sa fibrinolysis. At ayan na yan, sobrang summarized na yan dito sa nakikita nyo sa screen. We have the first step is yung inactive plasma protein natin na si plasminogen is mako-convert siya into its active form na plasmin. So, thrombin and other clotting factors activated during clot formation and tissue plasminogen factor released from the surrounding tissues, sila yung nagsistimulate ng conversion of plasminogen to plasmin. And over a few days, si plasmin, it will slowly breaks down the fibrin. And ayun lang, ganun lang siya kasimple yung fibrinolysis. So, for the drugs affecting blood coagulation cascade, Ms. Pepe.
So, drug affecting blood coagulation cascade, we have anticoagulants, prothrombotics, and antiplatelet. So, for anticoagulants, direct thrombin inhibitors, they exert their anticoagulant effect by directly binding to the active site of thrombin, thereby inhibiting the thrombin's downstream effect, causing non-formation of clot. So, for parenterals, we have argatroban, vivalirudin, hirudin, and melagatran. So, dito pala guys, pa-edit na lang. Melagatran pala yung parenteral kasi si semilagatran is the oral prodrug of melagatran and they are already withdrawn sa market because it causes severe hepatic injury. So for the MOA, it directly inhibit thrombin to delay clotting. So for next is for oral, we have the begatran. Um, it is the first oral direct thrombin that is approved by the FDA. So aside from the MOA niya na directly inhibit si thrombin, it also inhibit the activated factor 10. Next. And then, indirect thrombin inhibitors, parenteral, we have high molecular weight heparin, also known as unfractionated heparin or regular heparin. MOA is the form complexes with antithrombin 3 to inhibit intrinsic factor 9, 10, 11, and 12. So, tinatawag sila na indirect thrombin inhibitors because their antithrombotic effect is exerted by interaction with separate protein antithrombin 3. Ang ginagawa ni antithrombin 3 is ini-inhibit niya yung clotting factor proteases either activated factor 2, activated factor 10, activated factor 9, activated factor 11, and activated factor 12 by forming complexes. So, ayun. Yun dito is complex with antithrombin 3 to inhibit intrinsic factor. Kaya na i-inhibit si factor 9, 10, 11, and 12. And then for low molecular weight heparin or fractionated heparin, we have deltaparin, enoxaparin, proxyparin, and danaproid. So MOA is deformed complexes with antithrombin 3 and inhibit activated factor 10. Dito ini-inhibit din, nagpo-form din ng complex si antithrombin 3 sa activated factor 2 but on a lesser extent kaysa dun sa activated factor 10. Then next po. Then for direct thrombin inhibitors, indirect thrombin inhibitor oral, we have warfarin. MOA is it inhibit vitamin K epoxide reductase, thereby preventing the formation of active form of vitamin K dependent clotting factors, factor 2, 7, 9, and 10. So walang formation na ng clot na mabubuo. And then fact, act, fact, activated, sorry, activated factor 10 inhibitor. Yung parenterals lang pala dito is yung fondaparinux and then rivaroxaban and apexaban are oral. So it is also an indirect thrombin inhibitor. Its MOA is it specifically inhibit activated factor 10 by binding to antithrombin 3. Then next po. The next po. The next is prothrombotics. They are also known as antifibrinolytics, antithrombotics. These drugs are used in bleeding disorder. First is vitamin K. It promotes hepatic synthesis of clotting factor 2, 7, 9, and 10. So, leading to formation of clot. Then, tranexamic acid is a synthetic inhibitor of fibrinolysis. It inhibits plasmin formation. Then next. Then for antiplatelet, these are group of drugs that inhibit platelet from sticking together and form clot. Thromboxane synthesis inhibitor, aspirin, MOA is it inhibit COX enzyme, inhibiting thromboxane synthesis. So, COX enzyme, the cyclooxygenase 1, is responsible for converting arachidonic acid, which is a precursor of prostaglandin and thromboxane that are active compounds related to platelet function or aggregation. And then for adenosine diphosphate inhibitors, clopidogrel, ticlopidine, prasugrel, and ticagrelor, they inhibit adenosine diphosphate, which is a proaggregant at glycoprotein 3A and 2B receptor. So, adenosine diphosphate is one of the agonists that is present at the site of vascular injury and they activate the platelets by binding to specific receptor on the platelet surface, which is the glycoprotein 3A and 2B receptor. Glycoprotein 3A and 2B receptor, this is where the von Willebrand factor binds to produce platelet aggregation. And then, so, next is phosphodiesterase 3 inhibitor, silastazole and dipyridamole. It inhibits phosphodiesterase 3, preventing inactivation of cyclic adenosine monophosphate. So, phosphodiesterase 3 converts the CEMP into AMP or adenosine monophosphate. And cyclic adenosine monophosphate is important in inhibition of platelet activation. So when phosphodiesterase 3 is inhibited, there is increased level of cyclic adenosine monophosphate, thereby also increasing the inhibition of platelet aggregation. And then next is glycoprotein inhibitors, abscimab, terofeban, F-tibatide. They inhibit glycoprotein 3 and 2B receptor. So pag na-inhibit si glycoprotein 3 and 2B receptor, there's no platelet aggregation. Pabalik po sa fibrinolytics. So ayun dito pala guys, si fibrinolytics is drug siya that affects the fibrinolysis. So first is sorry. Fibrinolytic, they rapidly lyse thrombi or thrombus by catalyzing formation of serine protease plasmin from its precursor, zymogen plasminogen. So dito, basically you just activate the inactive plasmin to its active form, which is plasmin which causes fibrin to lyse. Streptokinase, it is a protein synthesized from streptococci that combined with proactivator plasminogen. It forms complex with plasminogen, which then converts plasminogen to plasmin, which also breaks the clots. And then tissue plasminogen activator, it breaks up blood clot formed by aggregation of active platelet into fibrin meshes by activating plasminogen into plasmin, causing fibrin to lyse. And then an isolated plasminogen streptokinase activator complex, ang ginagawa nila is it is a complex of streptokinase and plasminogen that does not require free circulating plasminogen to be effective. Its fibrinolytic action is theoretically selective to fibrin associated with thrombi. And lastly, urokinase. It is a human enzyme synthesized by kidney that directly convert plasminogen to active plasmin. Unlike sa streptokinase, urokinase directly cleaves plasminogen to produce plasmin.
Okay, so for the pathophysiology of hemophilia, as mentioned earlier, it is a congenital deficiency in a plasma coagulation protein results in a bleeding disorder commonly known as hemophilia. And the classic hemophilia, which is hemophilia A, is caused by deficiency in factor A, and the Christmas disease or the hemophilia B is caused by deficiency of factor 9, and tinawag siyang Christmas disease kasi yun nga, factor 9 is also known as the Christmas factor. For the pathogenesis, um, ayun, hemophilia A, as mentioned earlier then, it is an X-linked recessive hemorrhagic disease due to mutations in the factor 8, which is yung hemophilia A or classic hemophilia, or factor 9, which is yung hemophilia B or the Christmas disease. And since nga X-linked recessive bleeding disorder siya, ang most being affected ay yung mga males. Usually, young boys. Kasi nga, affected yung gene. So, bata pa lang, young boys pa lang, affected na sila. And yung mga women who carry a single mutated gene are generally asymptomatic. So, sila, carrier lang yung mga babae. For the clinical manifestation,
For the clinical manifestation, first is the hemartosis in young boy, meaning hemartosis is yung child joints is nagdudugo na. For the easy bruising in early childhood and excessive bleeding following trauma or surgery. For the signs and symptoms is weakness or Orthostasis is yung drop in blood pressure, joint pain, warmth, stiffness, and headache, stiff neck, irritability, meningeal symptoms like high fever, sensitive to light, and seizure. Hem hematemesis or yung patients is begins to vomit blood, and melena is yung black tarry stool and bright red blood per rectum, and epistaxis is yung bleeding from the nose or may acute hemorrhage sa nostril, nasal cavity or nasopharynx. Classic presentation is significantly prolonged bleeding after circumcision of hemarthrosis in a young boy, and notably no petechiae, purpura, ecchymosis, or platelet bleeding. For this image is yung sa left picture is yung it shows the severe knee hemarthrosis, and for the right picture yung sa paa niya is it shows yung less severe hemarthrosis in right ankle. Ito. Tapos ito na yung very severe hemarthrosis in the knee. For the screening and diagnosis first is the basic laboratory, which is the CBC. So, di ba sa CBC, it is the common test para to measure yung amount ng hemoglobin, size and number of RBC and WBC, as well as the platelets found in blood. So, sa patient with hemophilia A and B, yung CBC nila is normal. However, meron silang decrease ng hemoglobin and RBC in the cases of heavy bleeding or prolonged bleeding. And CBC will often show iron deficiency anemia due to subclinical bleeding. And di ba sa one of causes ng iron deficiency anemia is bleeding, and since hemophilia is inherited bleeding disorder. And for the coagulation study, is PTT or APTT or yung activated partial thromboplastin time and prothrombin time. Then coagulation study invariably show elevated PTT but normal PT and bleeding time. In the way na we need to know yung intrinsic and extrinsic pathway. Sa intrinsic pathway is it measures the partial thromboplastin time wherein mediated by factor 12, 11, 9, and 8. So sa patient with hemophilia A and B, the result of this test is will show a longer clotting time. So sa APTT makikita na mayroong deficiency sa factor 8 and 9. And for the prothrombin time, ito yung sa minimeasure sa extrinsic pathway wherein mediated by factor 7. Sa prothrombin time ng patient with hemophilia is normal siya, meaning walang deficiency sa factor sa extrinsic pathway. And for the factor assay, in other term is also known as clotting factor test. Dito malalaman natin kung anong type ba ng hemophilia diagnose yung pasyente. So sa coagulation study, 'di ba sa intrinsic pathway may deficiency sa factor 8, ibig sabihin yung pasyente is diagnosed ng hemophilia A. And for the factor 9, yung pasyente is diagnosed ng hemophilia B. For the treatment of hemophilia A and B will be reported by Mr. Ibala.
So good day everyone. So I'm going to discuss to you the treatment of hemophilia A and B. So the treatment of hemophilia A and B was classified into two, the non-transfusion therapy and the transfusion therapy. For the non-transfusion therapy in hemophilia, first we have the 1-amino 8 D-arginine vasopressin or DDAVP. It is a synthetic vasopressin analog that causes a transient rise of factor VIII and von Willebrand factor or the VWF, pero hindi sa factor IX. Through a mechanism involving release from endothelial cells, patients with moderate or mild hemophilia A should be tested to determine if they responded to DDABP before therapeutic application. So yung patient daw po natin is kailangan siyang i-test if kung mag-respond ba siya sa DDABP before i-administer po um, yung therapeutic application nito kasi hindi siya nag-work sa factor IX. It only works sa transient rise ng factor VIII tsaka von Willebrand factor. The DDABP at doses of 0.3 microgram per kilogram of body weight per patient over a 20 period is expected to raise factor VIII levels by 2 to 3-fold over baseline, yung peaking between 30 to 60 minutes after infusion. DDABP does not improve factor VIII levels in severe hemophilia A patients because there is no stores to release. Repeated dosing of DDABP results in tachyphylaxis because of the mechanism is increase and release rather than denebosynthesis of factor VIII and von Willebrand factor. Next slide, please. For the second non-transfusion therapy is we have the antifibrinolytic drugs. So bleeding in the gums, gastrointestinal tract, and during oral surgery requires the use of oral antifibrinolytic drugs such as epsilon aminocaproic acid or tranexamic acid to control the local homeostasis. Ang mawawala po ng antifibrinolytic drug natin is to inhibit the plasminogen activation and clot dissolution. Di ba ang goal natin is to stop the bleeding tsaka i-promote yung formation ng clot. So yung epsilon aminocaproic acid, it is a specific antidote for fibrinolytic agents. Also, adjunctive value in other conditions. The tranexamic acid, it is more potent than epsilon aminocaproic acid. From these two drugs, aside from having an antifibrinolytic activity, it is rich in factor VIII, which is deficient sa hemophilia. It also accelerates the coagulation process, which delayed during the hemophilia. The duration treatment is depending on the clinical indication. 1 week or longer, tranexamic acid is given at doses of 25 milligram per kilogram 3 to 4 times a day. Tapos yung epsilon aminocaproic acid treatment requires siya ng loading dose ng 200 milligram per kilogram. Yung max dose niya is 10 grams followed by 100 milligram per kilogram dose. Maximum niya is 30 grams a day every 6 hours. Next slide, please. So yung pangatlo natin is aggressive homeostasis, including bandaging and immobilization, emergent imaging if necessary. So for an example, there is an incident happened to a patient, tapos nagka-vascular injury siya. Then, severe na yung bleeding at madami na yung blood loss. Therefore, kailangan siya ng immediate na aggressive homeostasis performing bandaging and immobilization para ma-prevent na yung bleeding. Tsaka kung may internal bleeding naman or deep trauma, kailangan siya ng emergent imaging if necessary. Next slide, please. For the transfusion therapy in hemophilia, meron tayong primary prophylaxis. It is defined as a strategy for maintaining the missing clotting factor levels at 1% or higher on a regular basis in order to prevent bleeds, especially in onset hemarthrosis. Diba sabi kanina yung hemarthrosis is articular bleeding sa active bleeding active bleeding sa joint. Hemophilic boys receive regular infusion of factor VIII 3 days a week, 3 days per week, or factor IX 2 days, 2 days per week. Can reach puberty without detectable joint abnormalities. Prophylaxis has become gradually more common in young patients because yung standard care for children, prophylaxis is a standard care for children. However, teenagers and young adults do not always maintain the treatment regularly. Next slide, please. So we have the factor VIII and factor IX dosing units. Uh, 1 unit is defined as the amount of factor VIII, 100 microgram per ml, or factor IX, 5 microgram per ml. In 1 ml of normal plasma, 1 unit of factor VIII per kilogram of body weight increases the plasma factor VIII levels by 2%. One can calculate the dose needed to increase the factor levels of 100% in a 70 kilogram severe hemophilia patient with lesser than 1% using the simple formula. This formula, the factor VIII dose ay so yung dalawang formula na to is ang variables we need to consider lang dito is yung target factor VIII levels tsaka minus factor VIII baseline levels and multiply mo siya sa body weight ng patient in kilogram tsaka multiply sa 0.5 unit kilogram. Sa factor IX dose naman, ang variables you need to get is the target factor IX levels minus sa factor IX baseline levels multiply sa body weight ng patient in kilogram tapos 1 unit multiply sa 1 unit per kilogram. Next slide please. Next slide please. For the general considerations regarding the treatment of bleeds in hemophilia include the following. Treatment should begin as soon as possible because because symptoms often precede objective evidence of bleeding, detectable during circumcision if there's a severe bleeding. The superior efficacy of early therapeutic intervention, the medication have greater tendency to produce a desired effect pag nag-start ang treatment sa early age or sa onset. Classic symptoms of bleeding into joints or hemarthrosis in a reliable patient, headaches or automobile or other incidents require prompt replacement or further laboratory investigation. Drugs that hamper platelet function such as aspirin and aspirin-containing drugs should be avoided. Bakit? Kasi yung aspirin is nire-reduce niya yung blood's ability to clot. Therefore, it is recommended for the patient to use drugs such as ibuprofen and prophylactin to control the pain.
So, as you can see on the screen, this is a diagram of a treatment algorithm for management of patients with hemophilia A and factor VIII antibodies. First and foremost, the goal of comprehensive hemophilia care is to prevent bleeding episodes and their long-term sequelae so that patients with hemophilia can live full, active, and productive lives. Yung inhibitor formation na to, yung factor VIII antibodies, yun, parang ang term sa kanila is inhibitor. Ito yung most significant treatment complication na nade-develop sa treatment of hemophilia. And it is associated with significant morbidity and decreased quality of life. So, itong mga inhibitors na to, neutralizing antibodies to factors 8 and 9, they are known as inhibitors. They are developed in a subset of patients with hemophilia. And yung development ng inhibitors na to, ito yung most serious complication of factor replacement therapy. And as mentioned nga, they are associated with considerable morbidity and a decreased quality of life. So, paano ba sila nade-develop sa sa patients na may hemophilia. Paano sila nade-develop? Kasi nade-develop daw sila sa nade-develop sila dun sa replacement therapy, 'di ba? So paano nga? It is possible that the low levels of factors 8 or 9 in patients with mild or moderate hemophilia can induce immune tolerance in these individuals. Kasi yung factor levels ng patient na may hemophilia, um, parang basically undetectable na siya. Kapag may severe hemophilia ka na, yung mga factors na yun undetectable sila kaya nga sila nagiging deficient. So yung mga ini-infused na factors like factor 8 sa parang part ng replacement therapy dun sa mga patients na yun, nade-detect sila as foreign protein. Nade-detect sila ng body as foreign protein which may provoke an antibody response. So the development of an inhibitor is the result of a complex interaction between a patient's immune system and genetic and environmental factors. So, ano ulit, yung inhibitor na yon is um, a polyclonal high affinity immunoglobulin G directed against the factor 8 or factor 9 protein. These inhibitors interfere with infused factor concentrate, rendering them ineffective. And yung presence ng inhibitor na yon um, is suspected when a decreased clinical response to factor replacement is observed, or it may be discovered incidentally or on routine laboratory screening. So itong inhibitors na to, they are measured with the Bethesda assay, and titers are reported in Bethesda units or BUs. Patients with inhibitors sa factor 8 or factor 9 are divided into two groups. So meron tayong dalawang groups. I-classify natin sila as one is yung low responders na merong low levels of inhibitors, yung less than 5 BU per ml. They generally have little or no rise in antibody titers after exposure to the factor. And yung second one is yung mga high responders with greater than 5 BU per ml. Sila naman yung merong higher inhibitor levels and they develop an increase in antibody titer after exposure. So the therapy for patients with inhibitors involves the treatment of acute bleeding episodes and treatment directed at eradicating the inhibitors. As you can see on the screen, parang identify muna natin kung may bleeding episodes ba or wala so that alam natin yung approach. Kasi we can determine the approach to the treatment of acute bleeding with the aid of the parameters such as the inhibitor titer, the site and magnitude of bleeding, and the patient's past response to the therapy. So, sa mga patients na nakaka-experience ng bleeding episodes, yan, makaklasify din naman natin yung parang um, yung therapy or yung treatment with yung parameter dito is yung titer, yung inhibitor titer kung low ba or high. Ganun, sorry, ang gulo. So for patients with a low inhibitor titer, the administration of high doses of the specific factor can often control bleeding episodes. So 2 or 3 times the usual replacement dose and more frequent dosing intervals are often necessary to overcome this inhibitor or antibody. And also, factor level monitoring and clinical assessments can help evaluate the adequacy of treatment. And additional supportive measures such as immobilization and administration of antifibrinolytic agents should be used where appropriate. Kapag naman yung patients ay may high inhibitor titer, it is impossible to administer enough factor 8 or factor 9 to neutralize the antibody and achieve a hemostatic plasma level. Therefore, the treatment of bleeding episodes consists of agents that bypass the factor to which the antibody is directed. So, ano yung mga bypassing agents na to? Ito yung PCCs or the prothrombin complex concentrate, yung APCCs or the activated prothrombin complex concentrates, and yung recombinant factor 7A. And factor 7A, recombinant factor 7A, is effective for the treatment of acute bleeding in patients with hemophilia A or B na nagdevelop na ng inhibitors. Recombinant factor 7A is a bypassing agent that is hemostatically active only at the site of tissue injury where the tissue factor is present. Kaya siya nasabing effective. Para naman dun sa patients na walang bleeding episodes, syempre yung goal natin is directly ma-eradicate si inhibitor na na-develop. So the ideal therapy for patients with an inhibitor is total eradication so that optimal hemostatic treatment with either factor 8 or 9 is possible. So at this time, the only proven method for inhibitor eradication directly, 'di ba, is the immune tolerance induction or the ITI, which involves the regular infusion of factor 8 to induce antigen-specific tolerance. Pero take note, this approach is not recommended for patients with hemophilia B who have developed inhibitors kasi um, they are at high risk of hypersensitivity reactions and anaphylaxis associated with factor 9 administration kasi one of the major side effects ng factor 9 administration is yung hypersensitivity reactions. And lastly, immunosuppressive therapy may also help improve tolerance success with the use of cyclophosphamide and intravenous immune globulin. And once na na-achieve na yung hemostasis, pwede nang ulit bumalik dun sa maintenance factor 8 replacement. So, that's it. That ends our presentation. Thank you.